And we are ready to start. So I hope that everybody enjoyed lunch, and I am going to be talking about why I am so tired after lunch. And this is the best time to talk about a very important topic in neurology is why I am so fatigued, why I'm so tired. I mean, in the next few minutes, what I'd like to give you is an overview of a major problem in neurology that is called fatigue. And fatigue is not exclusive to myelitis, is not exclusive to spinal cord disorders. Fatigue is a common denominator of neurological disorders. And at this moment is almost 1:40, and this is the time of the day after lunch that you deserve a siesta. So please have the opportunity for having a good siesta. But if you want to pay attention to fatigue, let's talk about fatigue. And what I'm going to show you is an explanation that I always try to do when I am dealing with patients like you about fatigue, because fatigue, unfortunately, is a very complex issue in medicine. Again, fatigue is not exclusive to neurological problems. Fatigue is basically the common denominator of many health problems. So I need to acknowledge that at this moment I don't have any commercial disclosure, and I am going to use the name of some medications only and exclusively for educational purposes, and I am not trying to say anything about those medications in favor or against, but I need to understand that you understand that I am mentioning those just for education purposes. I need to acknowledge that our center has always received the support of the Transient Myelitis Association, and I encourage you to participate and help us to continue the efforts on patient care, education, and research with the Transient Myelitis Association, and in the near future with the Siegel Rare Neuroimmunological Association. So, fatigue. Fatigue is, unfortunately, one of the major disruptors of quality of life in myelitis, myelopathies, and neurological problems. And it's a very disruptive symptoms because your energy is gone and you don't have the ability to finish or perform your normal activities of daily living. So that is the reason we need to pay attention to fatigue. And it's a problem that influences the outcome of your rehabilitation and recovery. And when patients are fatigued, they have the right to say, I'm tired, I don't want to do more physical therapy. When patients come to my clinic and say, I am tired, I don't want to do physical therapy, I say, no, that's not a good thing to do. Because actually what we need to do is to modify the physiology of our body to go back and try to replenish energy and basically educate our body to use the energy in the proper way. So don't use the argument that fatigue is a major factor for not doing any physical activity of rehabilitation. You need to do it. The problem with fatigue is multifactorial. So fatigue is not because you had myelitis. Fatigue is not because you had NMO. Fatigue is not because you have MS. Fatigue is coming from different sources, it's coming from different factors, and I'd like to explain those factors to you in the next few minutes. So one of the major problems is we, as a healthcare providers, sometimes even don't understand what fatigue is. And we are trying to define fatigue, and actually, if you are neurologists in the United States or practitioners in the United States, what is fatigue? And some people have getting in meetings and discussing about what fatigue is, and they say, well, it's a subjective lack of physical and mental energy that is interfering in the activities of daily living. So that is semantic. That is just to define a symptom that is impairing the ability of patients to keep going in life. If you are asking British neurologists and physicians, you say, oh, there's a reversible motor cognitive impairment with a good accent, say, okay, you are tired. You are not able to finish your activities of daily living. But the most important part of this is that all of the effects of fatigue are going to disrupt activities of daily living, and they are influenced by many factors. Factors that are environmental factors, factors that are neurological factors, and even factors that are associated with something that we do, like what we did in the past hour, food injection. So sometimes patients come and say, I am very fatigued after having a good meal. Well, guess what? If your meal was heavy in carbs, you are going to be tired in the next 2 or 3 hours because your body is trying to basically metabolize that heavy intake of carbohydrates, and your insulin is jumping up and basically is trying to metabolize whatever you ate. So there are factors that are factors in the environment, like the heat, temperature. There are factors in our body, like the inflammation that is going on or happen in the brain or the spinal cord. And there are other environmental factors, what you are eating, the amount of carbohydrates that you are eating, the amount of protein that you are eating, and so all of those are factors that influence fatigue. Fatigue is very common to neurological problems, and this is actually a table from one of the neurology journals that summarize the different frequencies of fatigue among neurological problems. And you can see that transient myelitis is not here, and the reason is nobody has taken the time to study what is the frequency of fatigue in transient myelitis or in other neuroimmunological disorders that affect the spinal cord. There has been a lot of effort on studying multiple sclerosis. That is probably one of the neuroimmunological diseases that has been evaluated heavily in different aspects of neurology. And you can see that up to 83% of patients with MS experience fatigue. It's a very high frequency. But other neurological diseases like Parkinson's, strokes, myasthenia gravis, post-polio syndrome, ALS, I mean, all of those disorders actually have a component of fatigue. And the reason is neurological problems have a common denominator, weakness. When you are weak, you have difficulties in mobility, you need to expend more time and more energy. And that factor, energy, is a major factor for influencing fatigue. So neurologists that like to study fatigue have paid attention to two different things. One is the perception to be tired, perception to be fatigued. That is one thing. But the other thing is fatigue that emerges when you are doing something. In other words, when you are doing physical therapy or when you are exercising, you may complain about what is called performance fatigue. That is, in other words, affected or influenced by peripheral factors, the weakness that you have in your legs, the weakness that you have in your arms, the lack of muscle, the atrophy of your muscle. Those are peripheral factors that may influence the onset of fatigue. So that is associated mostly with performance. You are walking, and after 2 blocks, walking around, you get weak. That is mostly associated with that performance fatigability. And that may be influenced by central factors. That may be influenced by the amount of disease that is present in the brain or the amount of the disease that is present in the spinal cord. But there is another type of fatigue or perception of fatigue that is influenced by other factors. And this is extremely important, is the mood, the presence of psychological factors like frustration, like depression. So that influences this perception of being tired all the time. So you need to differentiate then two types of fatigue from your experience. Number one, the fatigue when you are active, when you are performing exercising other things, or the perception to be frustrated, to be with lack of energy, the mood change that is extremely important, and that's a psychological factor that influences the presence of that perception of fatigue. So following the same trend, what I like that you understand after this lecture is that you may be dealing with two different problems. One is problem derived from what we call the cognitive network and the brain network that is present in the brain. And that is a type of fatigue that we call central fatigue. In other words, if the NMO damage the brain, if the NMO damage the brainstem, the brain is going to have a network disruption that is going to influence the presence of fatigue. That's different to the peripheral fatigue, and as I mentioned before, that's one of the frequent problems that we have in myelitis, is you are losing muscle bulk, you are weak, you are using a lot of energy, and your body has an energy depletion because you are either over-exercising or you are basically struggling to stand up and walk, or you are basically having a very low resource of energy, and that is extremely important. And sometimes when we send you to the rehabilitation unit and to be seen by a physical medicine rehabilitation specialist, is that that person is going to guide you in the best approach, how to exercise, how to deal with activities of daily living. One of the frequent explanations that some of my patients that come to my clinic say, I ask, are you exercising, or you have a regular plan of physical therapy? And say, oh yes, I go to the gym, I have a trainer there, and I'm just going forward. And I say, no, well, it's good that you are going to the gym, it's good that you have a trainer, but you need to have a person to guide you and supervise you to make sure that you don't come to the situation that you produce energy depletion, or you do the wrong exercising, and at the end, rather than doing positive things, you are doing negative things for your body. So fatigue, again, depends on many factors. Central factor like the brain, spinal cord, but also peripheral factor in your muscle and energy storage and ability to use correctly energy resources in your body. I mentioned before depression. Listen, everybody get depressed. Chronic neurological disorders are a major factor for frustration and fatigue. And it's extremely important to take care of that, okay? It's very important to take care of that, because if you are frustrated and depressed, there is no way to keep moving forward. So it's extremely important that your healthcare provider helps you to find the best approach to deal with depression. Depression is a situational depression. Depression doesn't mean that you are a psychiatric person. No. Depression is a situational response to the impact that a neurological disease may have produced in your body. So you have the right to be depressed. You have the right to be frustrated. But we need to fight that. We need to coordinate that problem and make sure that your healthcare provider come and discuss with you the best ways to deal with depression and frustration. So let me go in a different type of view about fatigue. And I'm going to use three terms here. Fatigue that may be associated with the primary problem, or fatigue that may be associated with secondary factors, or fatigue that may be associated with comorbidities. Let me touch bases about fatigue, and this is the fatigue that is associated with the primary neurological problem. And Dr. Lana Herder in the next lecture is going to expand more on issues of brain connectivity and how those issues are going to affect fatigue and cognition. It's very clear that one of the major sources of fatigue is coming from the brain. And it's coming mostly because if there is a brain problem or is a spinal cord problem, there is a disruption of brain networks. And in the case of MS, that's very classical. MS produces a lot of damage in the white matter, and MS is going to disrupt the communication of many, many avenues that we have in the brain for communication. And that's enough to create a milieu, an environment that is going to produce fatigability. The same happened with other type of neurological problems. For example, in the case of NMO, NMO occasionally produces damage of the brainstem, and by producing damage of the brainstem, it's going to produce damage of a center that is called hypothalamus, and that is the master control of hormonal responses in your body. If a patient with NMO or patient with inflammation in the brain get disruption of the endocrine pathways, that's enough to produce a problem of fatigue. Why? Because the hormones that are normally produced are going to be reduced, and there is going to be a dysfunction in that aspect of your brain activity. We thought that inflammation was a major cause of fatigue, but the reality is inflammation is not. Inflammation may produce fatigue, but the main cause of the fatigability that patients with neurological problems experience is the disruption of those brain networks. But there is a second form of fatigue that is the secondary fatigue, and the secondary fatigue, again, depends on other factors. I put this graphic together because I like to emphasize in the two issues related with fatigue associated with central origin and fatigue associated with peripheral origin. And you already know this very well. The central origin is when there is disruption of all of these networks in your brain, and this is the result of damage by inflammation, by ADM, by NMO, or by multiple sclerosis. In the case of MS, that is very clear. In the case of myelitis, is the damage of the spinal cord that is going to produce this pattern of motor dysfunction that is going to lead to energy depletion, is going to lead to mechanical disturbance, and obviously that's the main cause of the problem. Let's go to one part that is extremely important as a secondary factor in fatigue, sleep disorders. If you are not sleeping well, you are going to be fatigued. Sleep disorders are very frequent in neurological problems and unfortunately are very frequent in myelopathies and myelitis. Why? Because if you have a myelitis, you are going to have pain, you are going to have spasticity, you are going to have cramps. And when you have that in the middle of the night, what is going to happen? Your sleep is going to be disrupted. How many of you have experienced that situation? Almost all of you, right? So cramps come in the middle of the night, you wake up, and then it takes 15 minutes or 20 minutes to go back to sleep, and then 1 hour later, the same. A sleep disruption is a major factor in fatigue in patients with myelitis and myelopathies. What is extremely important to understand is that you need to take care of the sleep disorder, and you need to discuss with your provider about best ways to take care of the sleep disorder. There is one major problem, and the major problem is, yes, let's go to medications, and let's use medications for cramps. Let's use baclofen. Let's use gabapentin. Guess what? Those medications, as a side effect, have an associated problem. And the problem is fatigue. So what you need to do is to make sure with your primary provider is, okay, I have a problem of pain, but if I take too much gabapentin, my mind is going to be disrupted. My mind is going to be basically in no good shape. So you need to get the best avenue to maintain the equilibrium of pain management with medication, right? So you need to be very careful, because if you are using gabapentin, Lyrica, amitriptyline, and all of these medications that produce a good effect on pain management, unfortunately it's going to produce an adverse effect on your sleep pattern. So you need to be cautious about the overabuse of medications. And frequently when patients come to my clinic with concerns about fatigue, I ask, tell me how much medication you have. Well, baclofen, gabapentin. Say, okay, good enough. Those two medications are good enough to produce a lot of fatigue. So what we need to do in those situations is just to make sure that we clean up medication that we don't need, but we leave you in medication that you need for fatigue. And it's a very challenging issue, and I will explain to you in the next few minutes why. This issue is critical. Depression is a comorbidity that is frequently influencing everything. Depression influences sleep disorders. Depression influences your ability to walk and the physical conditioning. So depression is affecting everything in our body. So again, make sure that depression is treated correctly and you pay attention to those issues. There are several medications that have been used for management of depression. There are medications that have been used traditionally, like modafinil, amantadine, that were introduced mostly as a medical treatment in multiple sclerosis to treat the fatigue in multiple sclerosis. Those medications actually have a lot of pluses and a lot of minuses as well. The main message that we have after several studies with all of the medications that I listed here, including modafinil, aspirin, methylphenidate, and many others, is in practical terms, the experience that we have with those is they are effective in a small group of patients, but unfortunately not very effective in the majority of patients. In other words, there is a weak evidence overall that those medications are effective. And that is extremely frustrating because we attempt to treat, but we don't get a very good response. And we need to acknowledge as healthcare providers that the medical treatment of fatigue is difficult, is associated with a lot of problems, and unfortunately is frequently not efficient. So you may try and see how your body responds, but keep on track with your medical provider and your healthcare provider and quantify the outcome of the treatment. But if at the end of several months on treatment you don't see benefit, just quit, because otherwise you are using more medications that are not necessarily needed. Unfortunately, the conclusion is we still need a lot of clinical trials to understand what is the best approach to treat fatigue. But the bottom line is there is weak evidence that all of these medications help. There are other non-pharmacological approaches. In the field of neuroimmunology and the field of myelitis, people have used different approaches. And you remember very well that summer in areas like Columbus, Ohio, or Baltimore, Maryland, are very rough, particularly because the high temperature and humidity. And people are going to strategies like using a cooling vest and using cryostimulation and other things. The bottom line is some of those are coadjuvant to help, but unfortunately haven't been demonstrated to be quite effective in controlling fatigue. It's very interesting. I was reading about yoga because I was very interested in yoga, and there are several studies, and probably later somebody can give us some advice. Yoga is very helpful, particularly for maintaining some physical endurance and other things. But for fatigue, actually, the studies that have focused on assessment of effect of yoga on fatigue have been very contradictory. So there are some studies that say, yeah, it's very good, and some studies that say, no, it's not good at all. So we don't have a good strategy with yoga in the management of fatigue. One thing that appears to be promising is endurance training, and that is one of the reasons I will encourage you to discuss issues related with endurance training with your physical medicine and rehabilitation doctor, because that may be an approach to deal with issues of fatigue. And there is tons of data in the past 3 or 5 years about exercising and improvement of mental capability and improvement of cognition with exercising. There are other type of approaches like neurocognitive approaches that appear to be some positive effects. And these are, again, experience derived from small clinical trials, but appear to be somewhat promising, but not necessarily well demonstrated to be quite effective. So these are tables, these are busy tables, but I want just to tell you in a few minutes that many medications that have been used for treatment of fatigue have provided good results and no good results. And the green means good results, the red means no good results. So you can see in this table that is a table that illustrates the different treatment approaches for fatigue in neurological problems, that the results are mixed. Not everything helps. And in the case of medication, actually that's worse, because in the case of modafinil, in MS that has been studied extensively, there are very contradictory results. There are several clinical trials that were negative and didn't help at all, and there are few that were very helpful. But the bottom line is many of those studies were based on a small group of patients, and we still need a lot of mileage to understand what is the best treatment for that. I will skip this because I want to go on this case, on this situation that is a typical patient in our clinic. This is Mr. X, that is a 52-year-old patient with transient myelitis, was diagnosed when he was 26. Later, he experienced optic neuritis and was left partially blind. What is the diagnosis? You already learned that. So what is the diagnosis? Optic nerve and myelitis is equal almost to NMO, right, or MOG. So that actually is a very interesting situation in this patient. And obviously, the patient is having problems with mobility, problems with blindness, so that is enough and a good reason to feel depressed. And the patient is not able to sleep, the patient has pain in the legs due to cramps, and the patient is using baclofen and gabapentin for pain management. So he's coming to discuss issue of fatigue. So the first question that I need to answer to this patient is, what are the factors associated with fatigue? So what do you think? Well, the first thing that I need to tell the patient is what is the diagnosis, right? The diagnosis is a patient that has a problem in the spinal cord and has a problem in the eye. So those two factors are critical factors to produce a right setting for problems associated with fatigue. First, because spinal cord damage is going to produce a dramatic problem with mobility and motor function, and that is energy depletion. And the blindness is actually going to produce a problem with the brain. You know what blindness is going to produce in the brain network associated with sleep? If you don't receive a good amount of sleep, your circadian rhythm is going to be disrupted. So you need to have in your brain something that we call circadian rhythm to be basically turning off and off your alertness, right? So for patients that are partially blind or with visual deficiencies, actually they are going to have more difficulties and more disruption in the circadian rhythm. So but this patient has a diagnosis of neuromyelitis optica. So what are the factors that are influencing fatigue? And you already are able to identify those, right? The factors are the patient is depressed, the patient is not sleeping, the patient has pain, the patient has a lot of medications for that pain. So the question is, what are the recommendations? The recommendations will be, okay, let's take care of depression. It's extremely important. We need to go and make sure that you are not depressed. The second is, let's change medications. Let's find the best optimal approach to deal with your pain and your spasticity and make sure that we control the cramps. So we need to make sure that we get a doctor who specializes in physical medicine and rehabilitation and establish a very good plan to deal with the limitations in mobility, energy preservation. And again, this is a situation that is very common in our clinic and is very frustrating. And you need to be patient and you need to go with your healthcare provider to deal with the different aspects and factors that influence the onset of that fatigue. Conclusion, what is the best treatment for fatigue and problems in myelitis? Do you know what is the answer? You can exercise and you can get a good guidance from the physical medicine rehabilitation doctor. You may modify the medications. You can treat depression. But one clue that I'm going to give you is take a lot of vitamin P. Do you know what is vitamin P? You don't know what is vitamin P? Be positive, okay? And be fighting all the time. You are frustrated. You are frustrated. You have the right to be frustrated, but don't give up. Just keep coordinating with your healthcare provider to clean up the medications, to give a very good quality of life, to avoid too much pain, and sleep better. So that's basically the approach that you need to have for that.